Great. Good morning, good afternoon, everyone. On behalf of WHO, I'd like to welcome you to this new webinar of the WHO ECHO Pediatric and Adolescent HIV webinar series. Today, we'll talk about dolutegravir introduction and discuss Odyssey trial results and share some key updates around dolutegravir introduction. Before we start, I want to just remind you that this webinar is being translated in multiple languages that you can select in your toolbar, in Portuguese or in French, that if you do have any problem, you can contact ECHO IT for support, and that the slides and the presentations will be shared with you at the end of this webinar. You are being recorded, and by participating to this webinar, you accept to be recorded. And we also want to note that you will receive a certificate of attendance after filling a survey that will be shared with you. As you know, these webinars are a result of a multi-step engagement that WHO has had with country programs over the years. And we are, through these webinars, reaching multiple countries to ensure that we provide the support that is needed for specific activities related to scaling up better services for children and adolescents living with HIV. And as you know, these webinars happen every month on the first Tuesday of every month. The objective is overall to really promote and support a platform for information sharing, but also to enable interactive discussion on progress and pending issues on scaling up pediatric and adolescents HIV services in priority countries. And so we hope that overall we'll be able to flag challenges, but most importantly, share solutions and trigger technical assistance where that is needed. As you all know, only 53% of children living with HIV are on ART today. And we know that they are presenting virological suppression that is consistently lower compared to the one in adults. A recent study led by UNICEF that will be presented in an upcoming webinar organized by UNICEF on April 20th has noted how, based on data collected in Uganda, Malawi, and Zimbabwe, 1 in 3 children did not achieve virological suppression. And that virological suppression was particularly low in the younger ones. Antiretroviral therapy. However, we know that there were multiple factors that related to the supportive environment and community.
Sorry to interrupt in between. Nandi, can you just join the Portuguese booth? You are in the English channel.
Sorry.
Yeah, thank you so much. Sorry.
My apologies. Okay, anyway.
So we know, therefore, that there are multiple factors that affect virological suppression. It's not just
different
factors. We know that treatment optimization is really the key first step to enable better virological suppression in children and adolescents living with HIV.
Sobre as crianças, nós sabemos que a optimização do tratamento,
ensuring that the right regimen are starting when children start antiretroviral therapy, but also that we change formulation as they grow and that better formulation are made available to them, that we transition them to better regimens when those become available, and ensure that they are switched to a proper second line when children fail on their existing regimen. So I'll go through some of these aspects one by one to really frame the webinar today. We know that WHO recommendations are already very clear when it comes to starting and switching antiretroviral therapy in children and adolescents. And we know that WHO guidelines already recommend dolutegravir for all children in need of first or second line ART. And today we'll hear additional evidence from the Odyssey trial, which further supports some of the recommendations that we already have. We also know that at the end of last year, we had really important news around approval of better formulations that now help enable us to implement dolutegravir across age and weight bands. And we know that this message is becoming very, very clear for multiple stakeholders at the global, regional, and country level, with wide support and endorsement to a rapid initiation and introduction of dolutegravir. We know that there's 2 generic formulations that have been approved by the US FDA. And we know that there is ongoing process for one of them to receive a pre-qualification. We also know that one of them is already co-listed on the WHO pre-qualification site based on the FDA approval. And there is ongoing work to ensure that these generic formulations are being approved in multiple countries. We have already provided dosing recommendation back last year, where we also noted that dolutegravir for children less than 20 kilos can be used also during TB co-treatment, with doubling the dose in the same way we do for adults. And today I want to share with you the preview of a new table for TB co-treatment, which is fully endorsed by the WHO convened Pediatric ARV working group, and that will be included in the upcoming consolidated 2021 guidelines to be released in July this year. And as you can see, this table helps you to really simplify the approach to TB co-treatment and ensure that the best ARVs are used, as well as that the appropriate dose adjustment is made for those ARVs once a rifampicin-based TB co-treatment is used. When it comes to transitioning to better formulation, we know that WHO guidelines already provide guidance on how to transition stable children to better regimens and better formulations. And the key question we have asked recently is whether these recommendations should be revised in light of the availability of dolutegravir from 4 weeks and 3 kilos. So we posed this question to the Pediatric ARV working group that really considered the programmatic transition to dolutegravir for all children that are established on first or second line ART. The group noted the individual and programmatic benefits that these transition would entail. They also noted lack of direct evidence in children, particularly for the young ones, in light of some concern that have been brought up in the scientific community around the effectiveness of dolutegravir with partially active NRTI backbone. However, the group noted that there is programmatic evidence suggesting good outcomes for children that are established on ART above 20 kilos, and we'll hear more about this today. And we've recently considered RCT data in adults that now support the use of dolutegravir-based regimen, even when there is partially active NRTI backbone. So as a result, the group really agreed and encourages rapid transition to dolutegravir-based regimen for all infants and children established on first and second line ART, irrespective of their current regimen. And the group noted that the timing of transition to dolutegravir-based regimen for these infants and children should account for availability and anticipated supply of pediatric dolutegravir. And in case of inadequate supply, when it's not possible to provide dolutegravir to all children, there is therefore a need to prioritize the children that are most in need of dolutegravir. And you can see here 3 situations in order of priority that should be considered. So if children are still on an NRTI-based regimen, if they need TB co-treatment, or if they are on allopurinol solid formulation with challenges in administration, that it's already suggesting that there's not suboptimal virological suppression. The most important thing is that the group agreed that while viral load is an important and it's really good practice when it comes to ensuring that children are adequately monitored, viral load testing should not be considered as a precondition to undertake programmatic and individual transition to dolutegravir-based regimen. And this is really an important concept to keep in mind. So we will make sure that these advice from the PWG is included in WHO guidelines. And as I mentioned, you'll find this text in the version that will be released in July. Today, we'll also have a chance to hear more about the revised optimal formulary and limited use list that, as you all know, is an important tool to really inform the minimum set of formulations that the countries should consider and use for treatment of children overall. So without further ado, I just want to illustrate the great agenda and speakers that we have today. I have two colleagues from the regional office and from the Kenya office, Dr. Salaba and Dr. Christine Kezie, that will facilitate the first session and the second session respectively. And we're really excited to see a lot of evidence being shared today, but also a number of important updates with regards to the programmatic experience that we have with dolutegravir introduction. So without further ado, I will hand over to our first speakers. But before I do that, and as we do that, I'd like to launch our first poll of the day. And so I'd like to ask our ECHO colleagues to launch the first poll so that we can start from that. So the question that we have for you is, has your country adopted WHO recommendation to use dolutegravir as a preferred treatment option in first and second line? And you can see there is a number of options: no, planning to, only for first line and for children above 20 kilos, for first and second line for children above 20 kilos, only for first line for all children above 3 kilos and older than 4 weeks, for first and second line for all children above 3 kilos and older than 4 weeks, and don't know. So please click on the choice that applies to you, and it would be great to see where you all are with introduction of dolutegravir in countries, and yeah, so that we can really set the scene for the conversation that we will have today. Let's give it a moment for people to respond. Hope many of you are contributing to this poll. So I wonder if ECHO colleagues, we could see where we are with the poll.
50% have been voted.
Okay, let's have a look. In the interest of time, let's look at what we have so far. Okay, so I see the largest proportion is recommending dolutegravir for first and second line for children above 20 kilos. But we see that there is a number of countries that do have different approaches right now. So hopefully the webinar today will help you really to consider this more and more, and look at some of the nuances that we are putting forward. So without further ado, I'd like to really introduce the first presentation, which will be led by Dr. Sisi Kito from the Joint Clinical Research Center in Kampala, and Dr. Hilda Mujuru, the University of Zimbabwe Clinical Research Center. And both Dr. Kito and Mujuru are among the investigators of the Odyssey trial, and they will present on behalf of the entire team, as also the investigator that contributed with the sites that contributed the largest to the trial itself. So I'll hand over to Dr. Sito to start off with the presentation.
Thank you, Dr. Martina, for the introduction. I will present the results of the Odyssey trial with Hilda on behalf of a very big Odyssey trial team. Next slide. So the Odyssey is an international multi-center randomized 96-week non-inferiority trial. The main aim was to compare efficacy and safety of dolutegravir with the standard of care across the different settings in children starting first or second line ART. The main trial was included children above 14 kilos. I think we've been talking about 20 kilos, but this trial had children above 14 kilos. Next slide. So the Odyssey trial was designed as a non-inferiority trial. And for the total Odyssey population, the non-inferiority margin was 10%. And looking at the different groups, Odyssey A or Odyssey B, the margin was 12%. So we recruited 707 children below 18 years of age who were either starting first-line ART, and that is called ODCA, or starting second-line ART. These children were randomized in 1-to-1 ratio to either be given a dolutegravir-based regimen or be on standard of care. And follow-up was until the last patient reached 96 weeks. Next slide. So the primary outcome was a composite outcome, including both virologic failure and clinical failure. And virologic failure was described as insufficient virologic response of less than 1 log drop at week 24, and ART switch for treatment failure. All confirmed viral load above 400 at 2 time points at any time after 36 weeks on the study. Clinical failure was any new or recurrent severe WHO3 or WHO4 event, or death due to any cause. Next slide. So the total population, again, was 707 participants. Median age was 12.2 years. The youngest we had was 2.9 years. We had 49% female. About a quarter of the participants were WHO stage 3 or 4. 22% who had CD4 below 200 cells, and 88% were African. As you can see the map on the right-hand side, those are the sites that participated in the Odyssey trial. Next slide. When we look at the third agent, the Odyssey, those that were on dolutegravir, Odyssey A and Odyssey B, all of them were on dolutegravir. And then in the standard of care, the Odyssey A, which was the first line, participants, majority were taking efavirenz-based regimens. And Odyssey B, they were taking PIs, the majority of whom were on boosted lopinavir. Next slide. And when we look at the backbone of NRTI, we didn't see any difference between the dolutegravir arm and the standard of care. Next slide. And similarly, we saw similar proportions on Odyssey B for the NRTI backbone. Next slide. So looking at the primary outcome, and this is the proportions with virologic or clinical failure by 96 weeks, we had an 8% difference between dolutegravir and standard of care arm. And the majority of these events were because of confirmed viral load above 400 copies per ml. The dotted line here shows the margin for non-inferiority. But as you can see, we clearly demonstrated superiority of dolutegravir-based regimens compared to standard of care. Next slide. We looked at the different arms separately. Odyssey A, again, is patients that were starting first line, and Odyssey B were starting second line. We looked at the events in both arms and separately for arm A and the Odyssey B. We did not see any difference in the arms as shown by the interaction of 0.16, which indicates that we can still say that superiority was observed separately in the groups of Odyssey A and Odyssey B. Superiority of dolutegravir over standard of care. Next. We also did an analysis looking at the per protocol analysis over 96 weeks, and we excluded about 6% of the population who had changed or stopped their third line drug due to various reasons. And if we look again at the total population and then ODCA and ODCB, we still see that DTG regimen is superior to standard of care. Next slide. We did look at different subgroups like sex, weight, age stratification, baseline viral load or baseline CD4, and we did not see any significant differences. So this is not shown. This is not shown, but we did analyze and we didn't see any differences. Next slide. We did an analysis by Kaplan-Meier plot. And as you can see, we showed benefit of dolutegravir evident as early as 48 weeks, and this continued up to 144 weeks. We may see a jump at 48 weeks in events, but this is because we did the viral loads at 48 weeks. So we didn't see these events earlier, and we only saw them when we did the viral loads at 48 weeks. Next slide. We looked again at the biological clinical failure by 48 and up to 144 weeks. And as you can see, 48, 96, and 144 weeks, we still show superiority of dolutegravir over standard of care. And we looked at interaction at all time points, and we didn't see an interaction. So we can conclude that even for the subgroups, there is superiority of dolutegravir over standard of care. Next slide. I'll now hand over to Hilda. Thank you.
Thank you, Ceci. So moving on, now we're looking at the deaths and HIV, severe WHO grade 3 and grade 4 events. And as you can see, Ceci told us 350 in dolutegravir arm and 357 in the standard of care arm. And when you look at the events, you note that under dolutegravir, we had 10 events from 8 participants and 8 events from 8 participants under standard of care. And that was not statistically significant. WHO severe stage 3 events, we didn't have any for DTG, but we had 1 for standard of care. But in the WHO stage 4 events, we had a number of events, 10 in dolutegravir arm from 8 participants and 5 from the standard of care participants. And we had 2 deaths in the dolutegravir arm and 3 deaths in the standard of care arm. Next slide, please. Thank you. So when we look at adverse events, you note that there were quite a number of adverse events in the dolutegravir arm. We had 65 from 35 participants. Note that 1 participant in the dolutegravir arm had 14 SAEs, 10 of which were anemia. And when you look at grade 3 and above events, there were 113 in the dolutegravir arm and 132 in the standard of care. And in the standard of care, you also note that 1 participant, a number of participants had raised bilirubin. There were 34 that had raised bilirubin due to atazanavir. So we had similar proportions of participants in the dolutegravir arm and in the standard of care arm. Okay, with more than 1 SAE or grade 3 events, and 83% of these SAEs were hospitalizations. But we had much more AT-modifying events, where we had only 6 in the dolutegravir arm and 17 in the standard of care arm. Next slide, please. Okay. So if you look at immune reconstitution syndrome, we also note that there were a number of iris events in the dolutegravir arm. There were 11 events from 10 participants because 1 participant had 2 events. It's severe malnutrition and suspected TB, and that patient unfortunately died. And then we had 4 iris events in the standard of care arm, from 4 participants. This was not statistically significant. So we note that the number of IRIS events were small, though in number, the number of IRIS events in the DTG arm was higher. This was not statistically significant. And most of these occurred in Odyssey A, which are the ones who were naive and starting out as a first line. Next slide, please. When we look at treatment changes, in the patients who were on dolutegravir, we noticed that 95% of them remained on their first regimen, okay? And if you look at standard of care, we had 89 remaining on their first regimen, 89%. So basically out of the 707, 92% of the participants remained on first regimen. Changing to second regimen, a lot more changed to second regimen in the standard of care, with 30, which is 8%, changed to the second regimen compared to only 8, which is 2% in the dolutegravir arm. And then changing to a third regimen, we had 5 in the dolutegravir arm and only 1 in the standard of care. And looking at the participants who had to stop at, there were much more in the standard of care, where 7 participants stopped at compared to only 3 in the dolutegravir arm. So a high proportion of our participants, 92%, remained on the first regimen, which was assigned at randomization, and switches to second and third line were common with the standard of care, much more than it was with dolutegravir. And the causes of the switch are listed there, but you can note that the standard of care had much more failure, with 21 participants failing compared to 2 in dolutegravir, and higher toxicity, 12 participants compared to 5 in the dolutegravir arm. Next slide, please. Thank you very much. So when we look at the CD4 count, you note that the mean CD4 counts, there was a marginal gain throughout. And you can see this, the blue line is the dolutegravir and the red one is the standard of care. And if you look at week 48 and at week 96, there was no significant difference in the CD4 counts. But overall, if you look at the mean CD4 cell counts that were the gains, they were marginally higher in the dolutegravir arm over the total follow-up period, and this was just significant with a P of 0.05. So, similar results were seen when you looked at the CD4 percentage. Next slide, please. Thank you. So if you look at cholesterol levels, with looking at the change from the baseline, and you'll notice that this is standard of care, which is in red, and the cholesterol levels were much higher when you compare them to the cholesterol levels in participants in the dolutegravir arm. So we had much lower cholesterol in the dolutegravir arm, and this was due mainly to differences in LDL. And there were similar findings when we looked at the triglycerides as well. Next slide, please. Thank you. So if we look at anthropometry, you note that the change in weight from the baseline, and we also look at the change in the BMI from the baseline. Looking at the weight, you will notice that there was a small additional gain in the weight, and the same applied to the height and even the BMI from the beginning early on, and it was steady throughout the study. And there was a higher gain for the dolutegravir arm versus the standard of care arm. But over the 96 weeks, mean additional weight gain was about 1 kg, and there was a gain of about 0.8 centimeters in the DTG versus the standard of care when you looked at the height. So the differences occurred early, and they were maintained both for the weight, the height, and the BMI. Okay, they were maintained through the study. Next slide. So in summary, we can say that we have shown that dolutegravir was superior to the standard of care based on virological and clinical failure at 96 weeks There was no evidence for different treatment effects in children starting first line, which was Odyssey A, and those starting second line, which is our Odyssey B. Similar results seen in the protocol analysis and the subgroup analysis. And there were no safety concerns for DTG. There were lower numbers of art-modifying events and treatment changes, okay, for the dolutegravir arm, which also had a better lipid profile. And these results support WHO guidelines in current rollover to DTG-based regimen for children, both for first line and second line. And this will allow harmonization with the adult treatment programs. For children who are below 14 kgs, we are hoping that the results are going to be available in the middle of this year. Thank you very much. Next slide. Just want to appreciate the partners that made this study a success, as the participants in Odyssey and the investigators, the trial management team, steering committee, the data monitoring committee, the endpoint review committee, our sponsor, Penta, and our funder, Viv and Mylan. We're grateful for all this support. Next slide. Next slide, please. Okay, so this is our last slide. Thank you very much. It just shows the many, many people who worked so hard to make Odyssey a success. Thank you very much.
Thank you very much to the Odyssey team for really sharing with us these important results. And I'm sure we'll come back to it later on, and really, please feel free to add your questions to the Q&A function. But before we move on to the next presentation, we have another poll for you. And so I'd like to ask our ECHO colleagues to launch the next poll. Where we would like to really ask your opinion about whether you think that the Odyssey study findings that you've just seen could help to implement the rollover to dolutegravir-based treatment for children in your country. Do you think it will help you? Do you think it won't help you? Or perhaps you don't know yet? So let's try to answer this poll quickly. I see we have many colleagues connected on the line. We have about 290 participants so far, which is great. And I hope many of you have the chance to respond to this question on the poll. So we'll give it a couple of seconds. And then in the interest of time, we'll move forward. So can we check with our colleagues if we got good number of responses? And
62%.
Okay, please, let's go ahead then and check. Great. I think that it's very clear that many of you think that these findings are very helpful to really introduce dolutegravir in countries more broadly. So thank you for that. So without further ado, I'll hand over to my colleague Salah Ba from the WHO Regional Office, who will facilitate the next part of the agenda.
Thank you, Martina, for handing me over the floor. It is now my pleasure to introduce Dr. Nandita Sugandhi. She is a senior program officer at ICAP at Columbia University. Nandita will talk about the updated optimal formula in limited use list for pediatric IL. Nandita, you have the floor, please.
Thank you so much. I hope everyone can hear me. And thank you for inviting me to speak about the 2021 revision of the Pediatric ARV Optimal Formulary in Limited Use List. And so before we start, I just wanted to review with the group that when we think about pediatric ARVs, that we actually think about it in different ways. We think about the regimen, which is 3 different ARVs that are given together. And we think about each ARV as the individual molecule or one drug that's in that regimen. And then in particular for children, we have to consider the formulation. So the ARV may come in different forms, but it's still the same drug. So here we have an example of LPVR, which is available as a liquid, as a tablet, or in solid oral dose formulations, such as the pellets or granules. And this really brings up the question of how many pediatric ARV formulations do we really need? So in adults, for example, on the top, you can see that regardless of size, regardless of age or weight, all adults will pretty much take the same drug. And currently most people living with HIV are taking TLD, which is 3 drugs in 1 tablet, and that can be given to all adults living with HIV as a one tablet regimen. However, for children, we have to think about different ages, different developmental levels, and different weights. And so as a result, we think about many different types of formulations or drugs being needed according to the specific child. And in fact, we actually have over 70 different pediatric ARV formulations that have been approved. Not all of them are still in use. However, over the years, we've really accumulated quite a few different, specifically pediatric ARV products. And so I think that this has become a little bit complicated, and the optimal formulary has been one strategy to simplify and reduce the number of formulations that we have to decide about for our programs. So in terms of the rationale for optimizing pediatric ARVs, we first limit the number in order to simplify programmatic decision-making around those products that are really needed to deliver the best pediatric ARV treatment. And that leads to easier prescribing. So our preference is for fixed dose combinations or dosage forms that are solid and can be dosed flexibly. And this leads to easier prescribing. Of course, we want those formulations that are supportive of adherence and easy for children to take and for caregivers to administer. And having a simplified formulary also streamlines supply chain and distribution. So it means that it's easier to get those products where they're needed to the pharmacies and reduce the risk of stockouts. And lastly, having a focused list of pediatric ARVs informs manufacturers on what specific products and formulations they need to focus their manufacturing on. And so really across the spectrum, there's a large need to rationalize the pediatric formulary. And so when it comes to looking at which pediatric ARV formulations are needed, the criteria with which we evaluate each product is we want to make sure that these are drugs that are WHO recommended and have been approved and reviewed in terms of safety and efficacy, that there's at least one product available that is quality assured, that has received stringent regulatory approval, that they're user-friendly so that they're easy to prescribe, easy for caregivers to administer, and supports adherence in children, and that it optimizes supply chain. So it's easy to transport, easy to store, and then easy to distribute. We also want to focus on those dosage forms that offer us dosing flexibility so that with a single formulation, we can allow for the widest range of dosing options. And then lastly, we think about comparative cost. And while cost should not be the deciding factor when it comes to the selection of a drug or a drug product, we do want to think about the comparative cost of similar drugs or drug formulations when it comes to selecting which drugs we need. And so with that, we have what we have defined as the optimal formulary, which is that minimum number of ARV formulations that are needed to provide all currently recommended preferred first and second line regimens for infants and children, as well as infant prophylaxis for PMTCT. And while this covers the optimal formulary covers all preferred first and second line regimens for infants and children. We do know that there are special circumstances. And so with that, we also have the limited use list, which is a shorter list of those ARV formulations which are included in the WHO guidelines, but will only be needed for a limited time or in low volumes. And as you can see, over the years, we've had a number of WHO recommendations for pediatric treatment, which has evolved over time up until 2018, where dolutegravir became the preferred drug for all populations older than 4 weeks. So all populations outside of the neonatal period, dolutegravir is really the preferred drug. And similarly, just as the WHO recommendations have evolved over time, the optimal formulary and limited use list have also had to change over time and become living products to evolve along with currently available recommendations, as well as the available ARV options that we have. And so this evolved from in the beginning, when it was in 2011, when the optimal formulary was first developed as a model list, it has evolved over time to become normative guidance. And it's now revised in accordance with WHO guidelines on a regular basis. And it includes those new optimal pediatric ARV formulations that have become available, while it also helps to phase out those products that are no longer needed or phasing out of use. The WHO optimal formulary has been endorsed by major global buyers of pediatric ARVs, including the Global Fund, PEPFAR, and UNICEF. And it's used by the ARV Procurement Working Group, or the APWG, to help coordinate global procurement of all ARVs for pediatrics. And it uses the optimal formulary and limited use lists in particular to follow trends in procurement and supply. So when it came to updating the optimal formulary in 2021, we started with our 2018 formulary, which is here on the left-hand side. And many of you may be familiar with this list, as these are the formulations that we've been using for the past few years in order to deliver the recommended pediatric first and second line treatment. And when we started with the revision process, we started with thinking through the additions for 2021. And as we've been discussing, dolutegravir really was the factor that led us to revise the formulary, and we were able to add the 10 milligram dispersible scored tablet that has been recently approved and is available now for use in infants and children down to 4 weeks of age and 3 kilos and above. So once we started with what we could add, we then moved on to looking through the rest of the list for what we need. So we recognized that we would still need a Bacavir 3TC, the 120/60 dispersible scored tablet, AZT oral liquid, which is for infant prophylaxis as well as for neonatal treatment, nevirapine oral liquid, which is also used for infant prophylaxis, LPVR tablets, the heat stable tablets, which are 100 milligram, 25 milligrams, which may be used for second line after failure on a dolutegravir containing regimen, as well as LPVR oral granules or the solid oral dosage form. And here I just want to point out that in the 2018 formulary, we had listed LPVR solid oral dosage forms of 40 milligrams and 10 milligrams to really encompass both pellets and granules. However, given that we are now shifting the majority of children from LPVR formulations to dolutegravir, we have less of a need for lopinavir, ritonavir for younger children. And the decision was made to really focus on the LPVR oral granules, as these could be used down to infants as young as 2 weeks of age, as opposed to the pellets, which could really be used in older infants from 3 months onwards. And Likewise, we would continue to need AZT3TC dispersible scored tablets, the 60-30 milligram for second line after failure on abacavir 3TC. And once we've gone through those formulations that we were adding as well as maintaining on the optimal formulary, then we moved into what we no longer needed, which was raltegravir. And we had included raltegravir, the 25 milligram chewable scored tablet, or I'm sorry, this was not a scored tablet, but the chewable tablet, which now can be replaced by the use of dolutegravir, as we can use it down to 4 weeks. And I want to add as well that although dolutegravir 50 milligrams is not a pediatric formulation, and historically the optimal formulary really only considered those uniquely pediatric ARV formulations, we did choose to list and maintain dolutegravir 50 milligrams as a reminder on the optimal formulary, as this is really a formulation that's critical to deliver dolutegravir-based regimens to children who weigh 20 kilos and above. And so we wanted to make sure that that this was maintained as a reminder to programs that the 50 milligram tablet is used not just for adults, but also in many children. And lastly, when we reviewed our 2018 list for what else was remaining, we came into the nevirapine 50 milligram dispersible scored tablet. And we didn't include this or maintain this on the formulation because this went over to the limited use list. And the reason for this, or the rationale for this, is that although we would prefer to use nevirapine oral liquid to deliver PMTCT infant prophylaxis, nevirapine tablets may still be needed in those instances where nevirapine liquid is not available. And so we did choose to move the nevirapine tablet to the limited use list, which is those products that are needed in small volumes or for a limited time. And in this instance, when liquid nevirapine is not available for prophylaxis. And then going to the, continuing on with the revision of the limited use list, we've gone through the 2018 list, and I'm going to start here with what formulations we no longer needed, and I'm sorry, what formulations we needed to maintain, starting with 3TC oral liquid, which again is needed simply for neonatal prophylaxis at this time. We also maintained raltegravir granules for suspension, which again are needed for neonatal treatment. And I'm sorry if I may have misspoken when I spoke to 3TC oral liquid, but that again would be needed for neonatal treatment, not prophylaxis. Darunavir is also required, and here we listed both the 75 and 150 milligram tablets that would be needed for third line, as these would be needed. Both these formulations would be needed in order to deliver across the pediatric age bands. And here we maintained the LPVR oral pellets as a product that is sort of now being phased out of use as we minimize the use of LPVR in favor of dolutegravir. And so that brings us to the remaining 2018 limited use list, which we were able to remove a number of different formulations because we now have improved options that preclude the necessity of these older formulations. So for a start, we were able to remove completely the use of LPVR oral liquid, as we have the granules that can be used down to age 2 weeks. And we no longer need the oral liquid. And in fact, many countries have phased this out of use. We also were able to remove the single drug formulation of abacavir 60 milligrams, which was really only indicated in order to deliver a triple nucleoside regimen during TB treatment. And this is largely because it was very challenging to provide any of the other alternatives. However, now with the introduction of a pediatric formulation of dolutegravir, as well as evidence from the Odyssey trial, we know that we can safely and effectively double dose dolutegravir for children who are taking TB treatment, and therefore the suboptimal triple nucleoside regimen is no longer needed, and we no longer need the abacavir single formulation. Ritonavir powder was also removed. We were not seeing uptake in use, and in fact, with the ritonavir powder, though it's available in a 100 milligram packet, it's not possible to divide that up into a lower dosage form. And as there is now the 25 milligram ritonavir tablet available, this is considered a better option in those circumstances where lopinavir ritonavir may have to be super boosted, or we need to provide boosting to an unboosted PI such as darunavir. We also removed atazanavir, and again, this is because we have seen very limited use of atazanavir in the pediatric population, and with the increasing availability of dolutegravir, as well as the availability of darunavir, there's really no requirement for the use of atazanavir going forward. So we were able to remove this from our limited use list. And we also removed AZT3TC nevirapine, the dispersible scored triple tablet. And this has been phased out of use now over the past several years. And we've really seen very limited use of this product. And really, as we have now much better options, we can completely phase this out of the formulary. And then lastly, with efavirenz, again, this is a drug that's been phased out of use, with more children transitioning to either LPVR or dolutegravir-based regimens, and it's no longer needed. So we were really able to streamline that limited use list of formulations that would be needed in specific special circumstances, such as third line, or that are being phased out of use, such as the LPVR pellets, or needed for very short periods of time, such as during neonatal treatment. And so with that, I want to leave you with the new 2021 pediatric ARV optimal formulary and limited use lists that are shown here. And I'm just going to say thank you to many of the people who are on this webinar and have participated in the revision. And we're happy to take any questions during the question and answer period. Thank you.
Thank you very much, Nandita, on this very important updates on the optimal formula for pediatric. Now we will be moving to our session, Q&A session. First, we have our Ugandan colleague from PATA who will be asking a couple of questions, I believe 2 or 3 from the provider perspective. And then we will take a few questions from our Q&A on live. So Dr. Violet Nabate is the head of pediatrics and adolescent services at Midway Hospital in Uganda. Violet, ask your first 2 questions to the panel. Over to you.
Thank you very much. Good morning, good afternoon, and good evening, everyone. I am happy to be here and under PATA, representing the frontliners. One of the burning questions that I've always had about dolutegravir use is about the blood glucose levels. We have had a lot being done for the adults and looking at hyperglycemia that's induced by taking DTG by the adults, and it's being monitored. So to Dr. Sisechitio and Tim, did you consider blood glucose levels in the children? Is it something important that we really need to look out for and consider to be able to monitor blood glucose levels amongst these children? If at all you did on the study, what were your findings? And is it a recommendation that we can always consider and prepare to do as we prepare to roll it out? Thank you.
Thank you, Violet. I have other members of the Odyssey team, they can chip in, but we did do fasting blood sugars on the children, and we did not find any differences between DTG or standard of care. Actually, we did not find any child with elevated blood glucose. And we've followed up these children for 144 weeks. So that is reassuring. I think you also, because the glucose is also sometimes related to the weight gain. And there was a slide that Hilda showed that didn't show a significant difference in weight gain between the two arms. So this is what we are observing, but Anna, can you chip in?
Yes, thank you, Cici, and good time of the day, everyone. That's correct. There was no difference in fasted glucose levels in dolutegravir between dolutegravir and standard of care arm, and we didn't have any new diagnosis of diabetes. We will have an extra look, on elevated glucose, but there was no diagnosis of diabetes in children during 144 plus weeks. Thank you.
Thank you, Violet. Other questions you have for live question? If not, we have questions on the Q&A, and I think some of the questions are related to the adverse events. One of the questions asking for if we have a long-term data on likely outcome of children transition to DTG while on a failing backbone. And the country that may already have resource to optimize viral load should probably be advised to optimize viral load coverage for easy long-term management of failing clients. The viral load check also helps ensure adherence issues are picked up and addressed earlier prior to transition, and potentially exposing the client to regimen that may potentially have single active drugs. Can you comment on that with the use of the viral load as not being a precondition for transition into DTG?
Sala, maybe I can chime in there because I think it relates to a slide that I showed at the beginning. And just to, I replied in the chat and the Q&A function already, but we unfortunately don't have data for the younger children, particularly for those that transition for abacavir, TC, lopinavir, ritonavir to dolutegravir containing regimen. However, I think that some of the other data we see in older kids and in adults are reassuring, and I sort of referred to that earlier. I think that it's clear that the countries are at different stages of viral load scale up, and we do acknowledge that there are some countries that might be in a position to use viral load effectively. However, I think that the Pediatric ARV working group really felt that poor coverage of viral load monitoring, as well as delays in result return and lack of follow-up actions might actually prevent children to have access to a better recommended regimen. And so really felt that it should not be a precondition for transition, and that was very clear. Now, I don't know if Anna and team want to comment, but I understand that while there is an ongoing studies around this specifically, we are hoping to perhaps learn a little bit more from the Odyssey trial and see if there is any subset of the kids that were enrolled in the trial that might potentially give us a better understanding of some of these nuances. And for sure, there are a couple of countries that are actively designing operational research that will help us to really monitor these children long-term and hopefully be able to really either be reassured or understand anything that might worry us and so be able really to document these things as they are implemented. So this is what I can say right now, but I don't know if Anna and others in the Odyssey team might want to chime in on that point.
Thank you, Martina. Sorry, Cici, do you want to go ahead?
No, go ahead. Yeah.
I just wanted to say that actually Cici and her team are working now on the resistance data. So we are actually analyzing as we speak, emergent resistant in the trial. And just wanted to say that we, in most of our participants, who like 88% were enrolled in Africa, we follow WHO guidelines. So it's was if a child would be failing on previous NRTI backbone with iodine 3TC, they would switch to a Bacavir 3TC mainly if they are under 30 kilos, or TDF 3TC if they were above 30 kilos. So most of our children would, those who failed in the first line, would be switching one NRTI, if switched to the second line. But we'll be looking at the baseline resistance and see if there is any helpful evidence, and hopefully, we can show something similar that Nadia trial showed, that you can maintain your NRTI backbone in spite of virological failure. But we don't have data yet.
Yeah.
Thank you. I see. Okay, go ahead. Who's speaking? Cecilia, go ahead.
Yeah, just to add to what Anna has said, I think we've seen that the resistance to the backbone or the NRTI drugs doesn't matter in adults. However, because there was another question in the chat about that, however, in the adults, we had tenofovir and mainly zidovudine as the 3TC in the backbone. The majority of the backbone in the children is abacavir, so we don't know if the result would be the same, but some of the resistance testing will show us, although we may not have enough numbers, and maybe we should be thinking of another trial to look at what happens if you fail on lopinavir, or if can we remain with the same backbone.
Cisse, maybe just one question to Nandita. I know you responded to the question regarding the lopi pellet and granule that are not tolerated at all. I think I would want you to go live to respond to that question so everybody can have
Sure.
your answer
So
on that.
so you're referring to the question about those
the lopirito pellet and granule that are not tolerated at all. Well, so what is the role do you see for the 4-in-1?
Okay, for the 4-in-1, so currently the 4-in-1 is not available. It has not, I think it's still undergoing review. So it has not yet been approved for use by any regulatory authority. So we're still waiting on that. I do believe that if it is approved and it does become available, the plan would be for the 4-in-1 to replace the granules and the other LPVR formulations. And so, but unfortunately at the time, at this point, we have not yet received word of its approval. So we're still, and so at this point, it's not an option for us to include on the list.
Thank you very much, Nandita. I think now our time is over. We will not have time to go for a break, so I will hand over to Martina for the next session, because we already at 4 o'clock, we were supposed to come back from break. So thank you very much for all the presenters on this session and the Q&A, those who answered the question and those who put the question up. Thank you very much. Martina, over to you.
Thank you very much, Salah. And I'll just hand over to our colleague Christine from the WHO Kenya office to facilitate the next part of the webinar. And thank you everyone for keeping the chat alive and for using the Q&A function to add your questions. We'll try to do our best to address all of those. Thanks. Christine, over to you.
Thank you, Martina, and good morning, good afternoon, good evening, good day to all of you. Thank you for the first session. So we'll move on to the next session and to take us through some of the experiences in implementation in the country. So I'm pleased to welcome Dr. Jason Bacha from the Baylor College of Medicine, Children's Foundation in Tanzania. Dr. Bacha will take us through the experience in the DTG experience in Tanzania and also Baylor experience in Eswatini. Dr. Bacha is an assistant professor and pediatrician at the Baylor College of Children's Foundation in Tanzania. Dr. Bacha, the floor is yours. Thank you.
Thank you so much for that introduction, and I will jump right into the presentation. So I think as we've heard that we know that efficacy and safety data of newer ARTs in children and adolescents will often lag behind adult data. And this can lead to hesitation and slow uptake by prescribers. As we've been hearing already, the early trial data on dolutegravir is very reassuring. However, these are well-organized research trials and often smaller sample size. In 2019, both Tanzania and Eswatini began their countrywide rollouts of DTG, including in children and adolescents. And thus, for this report and study, we wanted to look at some of the early characteristics and outcomes of the children and adolescents with HIV who were treated at the Baylor centers in Tanzania and Eswatini. This is just a quick map of the Baylor International Pediatric AIDS Initiative. On the right, you'll see the 3 green stars, Mwanza, Tanzania, and Mbeya, Tanzania, and Baban, Eswatini, which is what we focused this early analysis on. For our methodology, it was a retrospective review of our electronic medical records. And again, 3 sites, 3 centers of excellence in Mbeya and Mwanza, Tanzania, and then in Baban, Eswatini. We were looking at children and adolescents ages 0 to 19 who received DTG as part of their care. And our dates of analysis were March 2019 through November 2020. Of note, the available formulations in these sites were TLD as well as dolutegravir 50 milligram tabs. And throughout this, when I refer to viral suppression, we're using the country and WHO definition of viral load less than 1,000 copies. So for our results that we saw in our settings, during that time period, there were 2,846 children and adolescents who received DTG as part of their care. Looking at the figures on the left, this represented 65% of the total children and adolescents in our care on ARV. And when we limited it to those above 20 kg who are eligible, it was 82% of those. So it was a pretty aggressive rollout at those 3 Baylor sites. The formulations used are seen in the pie chart. Primarily, it was 60% on TLD, 35% on an abacavir-based DTG regimen. And then the table on the right just has a brief snapshot of the clinical characteristics of these children. You can see many of them were early adolescents who were ART experienced. They had a large proportion WHO stage 3 or 4 at diagnosis, though many at the time of DTG transition were a treatment stage 1, and about 65% were transitioned from an NNRTI regimen, 10% were new ART initiations, and the remaining 25% shifted from a PI regimen. As for our overall outcome results, they were very reassuring in this cohort of children and adolescents on DTG. We had nobody reporting severe drug toxicity requiring discontinuation of DTG, and up to 75% of these patients were able to utilize multi-month prescribing as part of their care. On the bottom left, you can see that 97% of these patients still remain active in care. 2.5% were successfully transitioned out, and the remaining 0.5% either died or were lost to follow-up during the period. The graph in the upper right shows of those who had viral loads pre and post DTG. Prior to the shift, 89% were suppressed, and after the shift, nearly 93% were suppressed, so almost a 4% additive gain. And then in the 2 figures in the lower right, We wanted to look at those who were unsuppressed, what happened, and those who were suppressed, did they remain suppressed? And again, reassuring results of those unsuppressed with viral loads pre and post. We saw 95% of the previously unsuppressed became suppressed. Likewise, of those with pre and post viral loads, 95% of the previously suppressed remained suppressed. So very effective in viral suppression. In addition to the overall characteristics, we wanted to look at a few unique situations in cohorts of patients using dolutegravir. So first, the group who remained unsuppressed on DTG. This was about 7.3%, 152 patients who had post-DTG shift viral loads. This table here shows the characteristics of the group who was unsuppressed compared to the suppressed. We were really just looking to see if there are any major differences. We didn't find too many striking differences. There was a slight higher rate of malnutrition in the unsuppressed group. There was a higher rate of ART exposure in the unsuppressed on DTG group. And then, which makes sense to us, the bottom row, if they were previously unsuppressed, or if they were previously unsuppressed on their former regimen, they tended to be unsuppressed afterwards. We really didn't see a major statistically significant difference between the type of regimen, whether it was a single tab TLD versus multiple tabs, though it was trending towards some significance. We were also curious, what about the single drug substitutions where the DTG was the only shift, but the backbone remained the same? This happened in about a third of our patients, 35%. And we saw a slight additive gain of viral load suppression of those that had both pre and post. Prior, it was right about just below 90%, and after just below 95%. And among previously unsuppressed in this single drug substitution group, 82% became suppressed. So again, we were reassured to see that even a single drug substitution with DTG was quite successful. We're also interested in TLD shifts. How did the patients who were shifted to TLD do? So of those who were previously in treatment failure and unsuppressed on TLE and then were shifted to TLD, it was a very small number, only 15, but 87% of them became suppressed. Of those that were previously suppressed on TLE and shifted to TLD, 95% remained suppressed. And then of those who are on a PI-based regimen with tenofovir, which are essentially a lot on second line, prior to the shift to TLD, only 64% were suppressed, and afterwards, a total of 88% were suppressed, with similarly high rates among previously unsuppressed and suppressed patients. We looked also at TLD use in the lower end, the 30 to 35 kg range, and again, it was successful with ranging around the 90 to 94, 96% suppressed depending on the cohort. Regarding the safety profiles of TLD, unfortunately, in many of our clinical settings, routine lab monitoring, extensive lab monitoring, such as renal function, just wasn't available due to lab stock out costs and other prohibitive factors in our settings. However, no patient showed severe clinical signs of renal or kidney failure. And again, there were no reported serious grade 4 or grade 3 toxicities and no discontinuations extracted during our data analysis. And then lastly, we were curious to see if there were any major differences in patients who received the single pill formulation TLD versus multiple pill formulations. And overall, we saw no statistically significant differences. Both had high rates of suppression, whether on the single TLD formulation or multiple tabs overall. And then when we looked more closely at those who were in treatment failure prior to the switch, again, similar rates were suppressed post switch, regardless of single or multiple pill formulation. Likewise, for those who are in treatment success and suppressed prior to the switch. So again, overall, our early experience, we were very happy and reassured that dolutegravir was well tolerated and quite effective in our clinically diverse cohort of children and adolescents living with HIV in our 2-country settings. We were also very pleased to see that viral suppression resulted in many previously unsuppressed patients. We saw that it was effective, whether it was a single drug substitution from TLE to TLD in the lower weight ranges, as well as whether it was a single tab or multiple tab formulations. So overall, we hope these early results can be used to really encourage the scale up and widespread use of dolutegravir in children and adolescents. Next steps within our group will be to look at the wider Baylor network to see if these results hold similarly as we incorporate the other sites and data from them sites, which is ongoing. So thank you very much for listening and allowing us to share these results. I know the question and answer time might be limited, so my email is here. I'm always happy to email back and forth with questions and more information about our data set. Thank you very much.
Thank you very much, Dr. Bacha. Thank you very much for that. That was a very good summary of the results and quite encouraging results. I'm sure the other countries will be encouraged in moving forward and also in documenting their experiences. Again, just to remind, you can post your questions on the Q&A, and I think also Dr. Bacha would be able to assist us with some of the answers. So we'll move on to give some country examples on product introduction. And to take us through that is Dr. Judith Kose from the Elizabeth Glaser Pediatric AIDS Foundation. Dr. Judith Kose is the Associate Director for Pediatric Services at EGPAC, and she'll be taking us through some of the country examples. Dr. Kose, the floor is yours. Most welcome.
Thank you, Dr. Christine, and thanks everyone, and especially for the conveners for inviting us. I'm going to talk about our country experience, and I've put on my video just for a minute just to wave. Otherwise, allow me to switch off my video so that I can optimize my network. So basically, from around 2019, EGPAF has been implementing 2 projects, around accelerating access to child-friendly LPVR solution formulations for those who are less than 20, and DTG 50 for children who are above 20 kilos. And this is work that is funded by both UNITAID and DNDi programs. So for the UNITAID funded programs, the 5 countries you see in brown, that is Eswatini, Lesotho, Cote d'Ivoire, Mozambique, and Zim. And for the DNDi funded project is Tanzania, Kenya, and Uganda, you see in blue. So these countries that I'm going to be presenting information from really accounted for approximately 35% of the total pediatric burden globally in 2018. And so learning from this experience, we identified key lessons to guide rapid uptake of new pediatric ARV formulations in future, and that is what I'm going to be sharing. So essentially, the support for these projects for rapid uptake of the pediatric formulations was around 1, policies and guidance and funding, so around support for updating national treatment guidelines and the EMLs, developing and implementing the national transition and rollout plans, support around procurement and supply chain, basically looking at existing stocks and ensuring that there's reduced use of the suboptimal products, as well as the stock management tools and training of staff, issues around development of materials and tools, and either to develop or to adapt, both for clinicians and caregivers, as well as capacity building around service delivery, capacity building for healthcare workers to prescribe these new formulations and monitor the children, but also for caregivers to be able to administer them, work around the use of monitoring of adverse drug reactions, the use of the reporting forms and strengthening the pharmacovigilance, as well as strengthening the client-centered models of care, such as the multi-month dispensing for children. So this is really the work that the project was focused on. So again, before I go to the country examples, just a flavor around the challenges we identified. So it was around, inadequate national transition strategies around the countries, poor alignment of the transition plans with availability of the new formulations, issues around delay in pharmacovigilance policy and tools, and systems to help track and quantify adverse events, insufficient capacity of healthcare workers, and also challenges with the caregivers, issues around reporting, and especially weak data and information systems to support quantification and to monitor the transition, and especially issues around the national reporting systems not capturing the weight data. We had data discrepancies from facilities to above facility level, data categories in the databases, not including the new ARV formulations, as well as lack of disaggregated data within the facilities. So I want to touch on a few country examples on the challenges and the solutions that we implemented across countries. So the first I had mentioned was around national guidelines and policy challenges. So again, across the countries, there was slow or infrequent updating of the guidelines and EMLs to accommodate these new pediatric formulations. So some of the solutions that were implemented included: one, governments issued circulars or memos to provide guidance on ART optimization while awaiting an official update of the national guidelines. In a country like Zim, they included DTG-based regimens, and the language had DTG-based regimens for all clients living with HIV as soon as formulations were approved and dosing guidance was provided. And so this embraced the DTG for children because of the language they had in their guidelines. And in other countries, the teams were able to secure special authorization from the National Pharmaceutical Authority to permit the use of the new ARVs formulation prior to EML update. Sorry, and the other challenge I wanted to highlight was challenges around supply chain challenges and some solutions. So the issues were many. We had countries that had the surplus of suboptimal legacy formulations, such as nevirapine and LPVR solutions. Some had shortages or stockouts at central and health facility level, such as shortages of LPVR 125 or 250, and even of pellets, and stockouts of similar drugs. And there's also a temporary decrease in the manufacturing production capacity while these countries were scaling up. So some of the solutions we had were including advocating for the MOH and donors to allow for wastage and disposal of suboptimal legacy formulations, removal of the legacy products physically from health facilities and returned to the warehouse, guiding health facilities on how to temporarily transition children from regimens in short supply to those with larger supplies. For instance, where they had shortage of LPVR 125, they would use other regimens. Unfortunately, in some instances when they had stockouts of LPVR granules or pellets, they actually resorted back to the suboptimal regimens like nevirapine, which was really because of the shortage. And also we had cases where we had redistribution of ARVs from facilities with larger stocks to those with shortages. An example I wanted to highlight is the product recall example. So in Tanzania, the legacy stocks of nevirapine and efavirenz were removed from healthcare facilities and taken to the zonal medical stores between October and November. And in Lesotho, the MOH, TWG agreed to recall nevirapine from facilities around May and June so that they could fast track the transition to optimal regimen. So again, some of the examples of how they managed some of the supply chain challenges. The other challenge I wanted to highlight is the service delivery challenges and solutions. So again, issues around healthcare workers to transition children or even to transition them to multi-month, a weak pharmacovigilance system to track adverse events, and like I mentioned, not enough stock for ARVs to provide multi-month. So some of the solutions we implemented included developing training materials and job aids or adapting them to use for rapid transition, orienting healthcare workers, including mentorship on how to transition children, labeling patient files and calling caregivers to facilitate prompt switching to optimal ARVs, revising tools, and also closely monitoring ARV stock levels and redistributed stocks at both facility and above facility levels to be able to manage some of these challenges. The other key challenge I wanted to highlight were caregiver capacity challenges and some of the solutions. So again, many of the caregivers had issues around the complexity of administering the pellets, granules, or tablets. There was limited guidance from the clinicians or lay counselors based on the feedback we were receiving from their caregivers, and also lack of customized caregiver literacy materials. And some of the solutions were including training of lay counselors and mentor mothers to teach caregivers on how to correctly administer the LPVR solid formulations, developing an adaptation of customized literacy materials for caregivers, including translating them into the local language, enhanced caregivers counseling during clinical consultations, providing bags for carrying the drugs when they get multi-month, refills, and also enhanced clinical and psychological support through phone calls and home visits to ensure treatment continuity and retention. So in terms of some of the data, I wanted to highlight 2 slides with data. So this is data from Tanzania, which was one of our 3 D&DI funded projects. So again, as of December 2020, 99% of children at our 210 supported sites had been transitioned to LPVR or DTG, and the 1% actually were around 29 children in the Singida area. Otherwise, in Arusha and Kilimanjaro, they had transitioned most of the children. And the strategies they used included allocating a site mentor to review every file and to ensure optimal package, inserting dosing charts in all the files, and coordinating ARV redistribution. Of course, they still had challenges in terms of the existing nevirapine stock and shortage of LPVR in one of the regions, as well as coding of the regimen. So these called for, managing the shortage and also training clinicians, including the data clerks, to be able to code the regimens correct. This slide shows progress on the 5 optimal projects that were funded by D&DI, and this shows one of the indicators, which was % of children on ART prescribed a new optimal formulation at the project sites. And as of December 2020, you can see many of the sites had optimized, and more than 80% of the children prescribed optimal ARVs were receiving the optimal formulation. As we were optimizing in these same 5 countries, we were also monitoring the progress of nevirapine phase out. And the indicator here was number and % of children living with HIV prescribed nevirapine at the project site. And you can see that the numbers really dwindled, and particularly we were monitoring Mozambique that had a high stock level. And they started from 37% at the beginning of Q3 2019 to as low as 3%. So again, success in terms of phasing out the nevirapine based regimen. So as I come to our end, some of the recommendations we did from this, we recommend from this in terms of guiding future rollout of optimal projects. One is to ensure there's strong coordination and leadership with MOH, either through technical working groups and other methodologies, to ensure there's a smooth transition from legacy to optimal regimens. The transition to optimal regimens must be planned well in advance, and this includes healthcare worker capacity training as well as caregiver education. It is important to ensure consistent and continual availability of the formulations. We had a challenge of stockouts or delayed supply in some of our countries. There needs to be some emphasis on pharmacovigilance and monitoring of adverse ARV reactions, as well as establishing a system to monitor progress. So once the transition plan is put in place, it's good to have a system to monitor progress as this is rolled out, and also incorporate learning from COVID into future transitions to the optimal pediatric ARV formulations. I have included here a link to our lessons learned brief that we developed from this work, and it's available in the public domain. So when you get these slides, you can use this link to read more about our experiences. And lastly, I want to really acknowledge our country teams that are leading this work, as well as my Geneva colleagues, under which the 2 projects are being run. Thank you, and I'll be looking out for questions in the Q&A section.
Thank you very much, Dr. Judith. Thank you very much for that. And thank you for the examples and the key lessons from the countries, and highlighting how the countries were able to go through some of the barriers and the bottlenecks. Please, again, just pose your questions at the Q&A, and Dr. Judith will also help us. We'll move on to the last session on procurement, as we have the issues on shortages, stockouts, production capacities. To take us through this is Dr. Caroline Middleton, who is the director of the HIV Access Program at the CHI Foundation. And also she'll be doing this with Dr. Christine Malati from the USAID. Dr. Caroline and Dr. Christine, the floor is yours. Most welcome.
Thank you so much. And I should just clarify, I'm actually not a doctor, but very pleased to be with you all here today. So I'll just quickly go through some high-level updates on the availability of pediatric dolutegravir, and Christine will provide some additional context on availability. So if we could just go to the first slide, please. So through this, sorry, this may not be the right slides, but I'm happy to speak to this. So through the collaboration with Unitaid, CHAI, and ViiV Healthcare and 2 generic manufacturers, we've been involved in making sure that pediatric dolutegravir dispersible tablets were made available as quickly as possible. And what we've now seen is that the originator pediatric formulation that had been originally developed by ViiV Healthcare received a regulatory approval in June this year. And by November, we had a generic version of the product available. So this is really exciting. And I think it shows the nature of this work and the collaboration that's really accelerated access for children. And what I think many of the people on this call will be critical to doing is making sure that that additional that further collaboration ensures that now we have these 2 tentative approvals of the generic 10 milligram dispersible tablets, that they become available at country level as quickly as possible. Through that, there was also a pricing agreement that set a benchmark price. And so we are seeing that this is not only a better product, but it's also coming in at a cheaper cost for governments. Next slide, please. Okay, so these are actually not the right slides. Maybe I can just
Caroline, would you mind then sharing your screen?
Yes.
Because I think that would be easier. Thanks.
Yeah, that would be great. Let me just do that. Sorry. Okay, 1 second. Perfect. And can everyone see my slides? Okay, so everyone can see that? I'll take that as a yes. Thanks. Great. Okay, perfect. So then, as part of this program, we really wanted to work to make sure that we catalyzed and moved quickly at every stage of the process. And what CHAI and Unitaid have done is done a catalytic procurement of the initial production volumes for the first supplier to make sure that the supplier can start to scale up as quickly as possible and get that production ramping up to really meet the needs, as we know that there's going to be a significant interest in scaling this to children widely across countries. And Christine will give an update into why we don't foresee having the same production challenges that we've had with some other products. So initial products will be available in Benin, Kenya, Malawi, Nigeria, Uganda, and Zimbabwe, and we're anticipating those to be made available and delivered into countries towards the end of this month and early next month. Next slide. Oh, I can do next slide. And just as part of this, while there's been, I think this call has shown really lots of amazing data coming out on use of DTG for children, we also want to make sure that when this new product, the dispersible 10 milligram, becomes available in countries, that we're able to capture data as much as possible. So there will be some operational research ongoing in Nigeria and Uganda, as well as other countries, really looking at how to use existing data systems to better monitor rollout. And as part of this initial access, we've developed lots of different implementation materials. So I just wanted to kind of give that plug to please use the new product introduction toolkit, which is linked in these slides. On there, we have training materials, so pediatric DTG. We have the latest kind of market intelligence, pricing lists, etc., to really help support implementation in country. And I'll hand over to Christine to provide some updates on when the product should be available for broader use outside of these initial countries. Thank you.
Great, thanks, Caroline. Dr. Casilla, could you switch to my slides? Great, thank you. So I'm here to give an update on the procurement and the orders that we've seen come through the US government channel, specifically USAID, and also an update quickly from the Global Fund orders. Next slide. So when we were preparing for our country operational plans or our work plans for early 2020, we started to collect information with regards to the ARV regimens that were being used in country. And this picture here is just a representation of some of the submissions that we saw. We saw countries submitting anywhere from 10 to 44 regimens. And so I think one of the anticipated updates with this very important transition to pediatric dolutegravir, where we envision at a minimum of 90% of children going to pediatric dolutegravir, is that we can begin to see a simplification of the number of regimens in country and a simplification of the actual formulations that are needed in country to sufficiently treat all children living with HIV. Next slide. And Caroline alluded to this, but I wanted to give you a breakdown on a weight band basis. If we consider the amount of product that would be required per patient per year, we can see that dolutegravir 10 milligram tablets actually cost significantly less than all of the current lopinavir formulations. I did not include efavirenz and nevirapine because we envision that all patients are now transitioned off of NNRTIs or will shortly be transitioned off. But I did want to just highlight the significant savings that can be realized simply by switching to dolutegravir tablets. Next slide. And the savings is not only related to the cost of the commodity, but it's also associated with the cost of shipping and storage. And so as we were preparing for this transition, we were asking countries to submit updated supply plans that take into account a dramatic reduction of lopinavir ritonavir formulations and an inclusion of dolutegravir formulations. And what we found is that some countries were misunderstanding that the ratio for lopinavir formulations to dolutegravir formulations is not a 1-to-1 ratio. And so this table below shows the correct ratios that should be used when forecasting for dolutegravir 10. So for example, a patient that is between 6 kilos and 9.9 kilos, if they were using lopinavir ritonavir 40-10 pellets or granules, and were switching to dolutegravir 10, they would need 1/3 of the number of bottles or packages. And so you can use these ratios to help when considering the transition and when considering updated forecasting. And so a switch to dolutegravir is not only going to save you in your budget in terms of the cost of commodity, but also related to the cost of shipping due to the lower weight of the product and savings in terms of storage capacity at your warehouses. Next slide. Wanted to give you an update on the countries that have already placed orders through the Global Health Supply Chain PSM Procurement Supply Management Project, which is implemented by USAID under PEPFAR. You can see the list of countries here that have already begun placing orders. We envision that the majority of these orders will actually be directly shipped from India to the countries between May and August to allow for introduction anywhere between July and October. Based on PEPFAR's policy, we are mandating that once product is received in country within 12 months, we would anticipate the transition to be fully complete. Next slide. Also just wanted to thank Mr. Gahal Mahir for his submission. He notified me that these are the countries that have submitted orders through the Global Fund mechanisms. So if you have not placed your orders for dolutegravir 10 at this point, I encourage you to do so quickly so that we can plan accordingly at the global level. The manufacturing capacity is very much exceeding the demand, and so there should be no challenges with regards to introduction and stock out, as we all suffered together the last several years with lopinavir, ritonavir formulations. We're very excited to support you in this transition. And with that, I'll turn it over to Dr. Christine Kassisi. Thank you.
Thank you, Caroline and Christine, for those updates on procurement and for your key messages. We've now come to the Q&A session, but before we open up to the floor, we'll first get a perspective from the implementers. We've heard of the country examples and also heard from procurement from both Christine and Caroline. I'll invite Dr. Violet. I don't know if your network is stable. I know she might be having an issue. Dr. Violet, to give us a perspective of the healthcare provider.
Thank you very much, Christine. Again, representing PATA as a frontline health worker at MyMay Uganda. We definitely always welcome the changes that happen in the guidelines for HIV management, especially for the children and adolescents. And how this moves is we get the guidance from Ministry of Health, and then it's cascaded down to the frontliners who see these children or who run the system. So first and foremost is for the staff to understand the science and rationale for the transition. For example, right now we have the transition to DTG. So we really have to make sure that our prescribers all understand. So we hold meetings to ensure we are training all the staff. This will include the nurses, it will include the clinic officers, it will include the doctors, practically everyone who is involved in a prescription, to be able to understand the science, because without them understanding it, then it's going to be very difficult for them to be able to work this out, because they're the ones who actually see the patients. Number two, we have to cascade this information to the caregivers, because I have come to understand as a pediatrician that when a child is failing on their ART, I have termed it the caregiver who is failing, because it's their role that is not being achieved at 100%, because you can't tell me that a 2-year-old is failing on ART. So while these mothers or fathers or other caregivers come into the clinics to attend the clinics or to bring the children up for their clinical care, we always have the health education talks, giving them updates on all that is happening. Even when it is transition, we have to make sure we address them so they understand why we are doing the address, why this change is happening, because usually when you bring in a lot of changes at the same time, they end up getting disturbed, but they really need to also understand why this is happening, because if I transition without having them know, the implementation is going to be difficult back home because they don't understand why we did this. So this is very, very important. As they wait in the waiting area, they get this information, and even as a one-on-one in the clinicians' rooms, they still get it. But we also have champions and peers who have gone through this system of transition, and they are also able to keep giving them this information as they wait. We always have to look at why we transition, the benefits of transition, and the disadvantages of not transitioning. For example, one of the fears we have is we must transition because the stock is coming in. And if we do not transition at 100%, what is going to happen to the stock we were taking before? So high chances that we'll not have it anymore, and you have not transitioned, so you really do not have the right treatment that you're going to give to these children. And then we have to go through the considerations. Viral load has been high, but I am happy because from the Odyssey trial, it has been able to tell us about the viral loads, but also we are understanding with the new formulations that we may not necessarily have to consider the viral load. In some areas, there are challenges of viral loads coming in late or not getting the results on time. And then you can't hold so much waiting to transition because there's no viral load. However, we know that dolutegravir will actually just help us crush the viral loads. So looking at the viral loads, then the weight measurements for us to be able to get the right weight, that will take the 10 milligram tablet, 20, 25 milligrams or 50 milligram tablets. And the children have changing weights. So the weights are very, very important. And these are done to really determine what score tablet they are going to take. But also we have to consider the age of the child, because sometimes we have a child who is 5 years old and the caregiver tells you this child only takes syrup. So we really need to end up weighing to see what exactly does this child take. Can they be able to take the tablet, for example, as the case has been for lopinavir?
Have we lost Violet?
Yes, Christine, I think that she had some connection problems.
Yeah, there seems to be some connection problem. I think the internet is on and off. I think we might have lost Violet, but Violet had covered a lot of the key considerations of the healthcare providers in DTG transition. I think she had already answered most of she had already given us a lot of the perspective. I think we can open up to the other Q&As. Most of them I've seen that they've been responded to on the chart. I think there's one on the genotype testing among those who shifted to DTG. Is there somebody? I'm trying to see if we've lost. No, we still have people online.
Christine, I'm not sure I was clear about the question, so I wonder if the person that posed the question would like to add a few more details so that we can fully understand and address the question.
Okay, so the question is being posted by Paul Nyasulu, I think on the experience of genotype testing among those. I think this was from the first session on the ODC trial. I think, but Paul, if you'd please provide more details for your questions. Maybe just highlight a few of the other questions, although we've
Christine, I wonder whether it might be helpful for Christine Malati to perhaps share live her response to the last point on lopinavir ritonavir. Christine, I think many countries might have the same question. So,
okay, so Christine,
sure.
go ahead.
Certainly. So we at U.S. government across all the PEPFAR implementing agencies have really been grappling with lopinavir, ritonavir in country. And so I think that what's important to note, I think from this situation is that, well, number one, for future transition, perhaps we need to consider carrying less stock in country so that we might be more nimble in our ability to transition to new formulations. So that's one point. The second point being that we know that viral load suppression rates are low, remain low. We know that children anecdotally are not tolerating the lopinavir formulations across the different types of formulations, solution, granules, pellets, and whatnot. And we know that there are some challenges with swallowing the heat stable tablet 125. So across the board, all children will benefit from the new dolutegravir scored dispersible formulation. And so if we consider the QALYs or the quality adjusted life years, and if we were able to do a sophisticated health economic analysis, we would find that the benefit for our program at large in terms of introducing dolutegravir as expeditiously as possible far outweighs the cost of lopinavir that has been spent on lopinavir formulations in country, and far outweighs the cost of destruction of lopinavir ritonavir in country. We simply have we simply owe it to our children to bridge that gap in viral load suppression rates. We now have the tools, we now have the resources. So really the time is now to begin introducing dolutegravir as expeditiously as possible. Over.
Thank you, Christine. We have a question also on the procurement lead time of DTG 10 milligrams.
Sure. So, and we've been in close conversation with Viatris even before they received their approval, and also with Macleod's. And so with the initial orders are going to be coming from Viatris since Macleod's just recently received their approval. They have indicated to me that if an order is placed, let's say today, then within 8 weeks, we would be able to pick it up from India for shipment to sub-Saharan Africa. So you can envision about 3 months or so between the time of order to the time of delivery, at least through the USAID channels. I can't speak for the Global Fund channels. Over.
Thank you for the reply, Christine. I'm trying to Dr. Martina, would you like to add more information on this one?
No, that's absolutely good.
Okay.
I also noted that Paul Nyasulu has added additional clarification to his question. I think he was referring to the 5% that suppressed post-transitioning to dolutegravir. So I wonder whether that was about the Jason's presentation, correct?
Yeah, this was the one from Tanzania, Dr. Bacha.
I can quickly comment. HIV genotyping is not routinely available at our site, so we don't have complete data. However, we've had a few patients enrolled in other research studies who got them, and we have at least 2 or 3 patients, not a large number, who their genotype showed pan resistance to the PIs and NRTIs and NRTIs who were shifted to a DTG regimen and subsequently suppressed, which again was very impressive and surprising in a good way for us to see, but very anecdotal numbers.
Okay.
Christine, if I can chime in, there is another question which I think we touched on before, but just to reiterate that we currently don't have any data, resistance data for children that transition to dolutegravir-based regimen with a single drug substitution. And that data might come up from the sub-studies that the Odyssey team has mentioned earlier. So more information might come up from Odyssey or from operational research that countries are currently considering. So we don't have information right now, but we hope to have more soon.
Thank you, Martina, for that. Yeah, I think that's been asked twice, so it's good to reiterate that. Is there another question that has not been responded to? I think our time is also coming up for the Q&A session, and if you would like to close it for this session there. So I would like to thank all the panelists, Dr. Judith, Caroline, and Christine, and Violet also, for taking us through these very important sessions, and also to all the people, the participants, and the people who have been asking and interacting in the Q&A session. And everybody, apologies for the interruption in the network. I know some people dropped off, but were able to come back. Thank you very much, and I'll hand over back to Martina to close.
Thank you so much, Christine. And yes, indeed, a very rich session as the second part of this webinar today. So I'll just take the last few minutes just to wrap up. And I think we've heard a lot today. And so I'm not really able to summarize everything. But I think the key key take-home messages are that the auditive results that the team presented to us really support current WHO guidelines, both in terms of efficacy and safety, which is certainly reassuring. We've also seen country experience with dolutegravir introduction, which again is encouraging and supports rapid introduction of dolutegravir, with all the caveats, of course, that some of the children that have been transitioned right now might not necessarily be the younger ones, but certainly findings that do hold promise. We've also been reminded of the essential actions to support rapid uptake of new formulations. And I think the experience that the ECPAF team shared was very useful and practical when it comes to introduce new formulations. And so I hope we can all go back to some of that material that Judith mentioned. We've heard that from Caroline that catalytic procurement is starting in a number of countries. So it's very exciting to see how the pediatric 10 milligrams core tablets are becoming available very quickly in many places. And we've heard from Christine Malati from PEPFAR that there's no anticipated concern with dolutegravir supply. And so countries are really encouraged to place their order if they haven't done so. We've also heard from Violet that there is a lot that obviously needs to be done to prepare the ground to do so. Important in particular to support with adequate information healthcare workers, to train them and ensure that they are supported as this transition occurs, and obviously that the support is provided to caretakers as well. They really do need to understand why this transition is happening. And finally, we really hope that the new optimal formulary that Nandita has shared with you all is going to remain an important tool for country programs to really select the programs that are needed and really support your scale up to optimal pediatric treatment for different age and weight bands. So with that, I want to conclude just by reminding you that unfortunately we're still very much affected by the ongoing COVID-19 pandemic. And we know that many of your countries are actually facing a surge in cases these days, but it's important that we really remind ourselves that once some of the restrictions are lifted and when our patients come back to the facility, it's important that we maximize the opportunity of contact with the patients and their families, and that we really try to provide all the services that they need and they may have missed during the pandemic, so that we have an holistic approach to the family and ensure that they are placed at the center of what we do. We also wanted to note that our WHO website has been updated with new tools, and so you will find it here live right now. And with that, also the AIDS-Free Toolkit, which remains a place where we include a lot of the tools that our partners and colleagues have developed to really support scale up of treatment and care for children and adolescents. Of course, we will continue this webinar series in the next few months, and the next one is going to be very important because it will give us an opportunity to focus on the new WHO guidelines on service delivery. And with that, we will be able to reflect on implementation of DSD for children and adolescents, psychosocial support for adolescents in particular, and then maybe think about how we can promote and support task sharing and decentralization for children, which we know is something that we haven't really perhaps implemented and scaled up enough. And all of this obviously with additional updates and country experience, which really makes this webinar very, very rich every time. So with that, I want to thank all the speakers for their contribution to today's webinar, all of you for attending the webinar, and Kadi Irvine and Asma Hafiz for coordinating the preparation for this webinar. We really appreciate their support, and thank you again for your attention and for your time today. Bye, everyone.
Bye. Thank you.
Bye, Martina. Bye-bye, everyone.